Hi, everybody. Now for something completely different. Okay. So I don't think anything I'm going to tell you is going to change what you do every day as surgeons. But I'm hoping it'll get you to think a little bit differently about the patients you see every day as surgeons, especially your obese patients, and think about some of the stuff you can do when you're not at work. So we know life expectancy is increasing for lots of good reasons, but we also know that this is disproportionately benefiting high income and, in our country, white populations. So in our country, a poor black man lives 14 years less than a wealthy white woman. Around the world, there's also big disparities in life expectancy. And over the years, we researchers have done tons of studies showing tons of reasons for these disparities, but we don't have as many solutions as what to do about them. So we know what we're learning is not translating well enough into what we're doing, which is having us do two things. One is think differently about what some of the other causes are we haven't addressed and do differently. So I'm going to talk a little bit now about one of the reasons for poor health and these disparities, which are surprisingly unrelated to healthcare, and they're not simply behaviors and personal choices. And I'm going to look through a diabetes lens. I don't know if you've heard that term before, but it's the combination of diabetes and obesity, which go hand in hand very often for type 2 diabetes. And we'll look at some solutions. So take a middle-aged woman you're seeing for pick something, who also has obesity, diabetes, hypertension, hyperlipidemia, on a bunch of meds, nothing's perfectly controlled, managed Medicaid, limited English proficiency. Anyone ever not seen this patient?
Or got a pole match.
So, and we know that obese surgical patients have increased risk of all sorts of perioperative not good things. We heard about it today already. But what we're going to do now is we're going to look beyond our individual question for this patient of why do you weigh so much? We've been doing everything we can for you. What is wrong? Do you care? Do you get this? Where is the disconnect here? And I want to shift our lenses back from that individual patient to larger systems, because I think it's bad for our patients and patient care if we don't look at the bigger picture of what's going on. And I want us to look at social determinants of health, which is where she was born, where she grew up, where she lives, and where she works, because these are really what's primarily responsible for these inequities, and health inequities are what we consider unfair and avoidable differences in health status. So we know there's multiple determinants of why we're ill and why we're well. And medical care access probably is about 15% of our health has to do with what we do here. Health behaviors may be another 15%. They're not the main driver. We have genes, but the main part of why people are sick and well has to do with these other determinants, things that we in the hospital can't control: employment, housing, safety, income, all these different kinds of things. One summary of how you can see the difference is looking at just where people live and how long they live, and what they do and how long they live. So here on this side, you see people looked at the differences in life expectancy based on the kind of job you have and your gender. So you can see that in all cases, men live shorter lives than women, but as you go in both for men in green and women in brown, from professionals down to unskilled manual, look at the differences in life expectancy. So how you live based on your gender and where you work. Over here is a map of Washington, and you can look at the different metro stops. And what you can see here is just life expectancy differences based on where you live in a smaller neighborhood area. Pretty big differences in life expectancy. And in this study, what they found is that even within these small neighborhoods, if you live here or here or here or here, whichever neighborhood, blacks have higher mortality. Blacks die younger, even if you control for their individual income, smoking, alcohol, employment, access to care, exercise, BMI, social ties. So we have real differences. So what we're going to do is, I want to, because this is a huge topic, I want to narrow it down to one specific area and look at how this all plays out through this diabetes lens. You all know we're gaining weight. The world is gaining weight. We are told to sit down, watch TV, and eat junk. This is becoming easier to do. It's becoming cheaper to do, and our world is gladly obliging. But this message, and I'm going to show you, is disproportionately sent to and received by people who are low income and from minority communities, who also have an obesogenic environment, which I'm going to describe. And of course, in hand with this, diabetes prevalence and complications are increasing. People are living longer. Almost every disease has decreasing mortality. One of the major divergers of this is diabetes, where mortality is going up. And disparities are going up as well. So blacks and whites are separating in terms of how they're doing. Here's our road. This is where we are right now. In our population, you can see that a minority of us are not overweight. In the black population, it's almost a majority that are obese. We are getting up to the point where close to half are developing pre-diabetes, sugars higher than normal, but not diabetes yet, and more diabetes. So you think you're busy now with all this. Without more prevention, by 2025, we're assuming that a third of American adults and half of African Americans and Latinos will have diabetes. So this is the storm before the big storm. And globally, this is explosive, absolutely explosive. Obesity has more than doubled since 1980. 1 in 10 adults worldwide is obese. Now, more people live in countries where overweight kills than underweight kills. We kind of went from starvation to obesity and skipped that step in the middle. And this is huge, huge worldwide. And I do work in developing countries, low and middle income countries. This is really, really terrifying to people in developing countries who are not sure how to handle this. So diabetes is expected to double around the world, and especially in developing countries. This is where it's really going to grow. Mexico, by the way, has the fastest growing rate of obesity in the world. So we know that this is, people get fat and people get diabetes because they take in too many calories and they don't burn enough calories. But it's also from what I'm going to describe, which is called obesogens. And even what we eat and how much we move are really impacted more by our will than just our willpower, and our culture. So what I'm going to do is I'm going to take you to 4 areas which I think don't get as much attention that I just thought you might want to know about in terms of beyond culture and behavior, what are some of the things that are causing this obesity and diabetes epidemic? So I'm going to start out by talking about some policies. So here's one policy. So you guys know the Farm Bill is up now, and they're trying to decide what to do about the Farm Bill. Fruits and vegetables, according to the Farm Bill, are called specialty crops. And what's happened is that we do subsidize mostly corn, meat, and some wheat, but we don't really subsidize any fruits and vegetables. So what happens is the farmers have an incentive to grow more. They get a subsidy. We have an incentive to eat more. They're cheaper. And this is what happens. So for example, I don't think high fructose corn syrup is worse for you than regular sugar, but it's really cheap. So what you see here is if you look at the consumer price index over the last 20 years, you can see that relative price of soda has stayed pretty good. Sugars and sweets have stayed pretty low. But look at fruits and vegetables. So if you want to keep eating the same amount of fruits and vegetables, you have to put more of your paycheck toward them. And this won't change with the Farm Bill. So here's another policy I want you to look at called residential segregation. What this is about is, you think about the fact that we're on the border of Upper East Side and East Harlem, 2 really different neighborhoods. And what we know is where people live is affected by all sorts of policies that we have. So in the late 20th century, white middle class started migrating to the suburbs. And what happened in some of the inner city areas is our policies and our structures started to crumble. Resources got divested, there was redlining, and there were major changes in land use and zoning. So we started allowing bus depots, fast food and alcohol in, supermarkets and businesses went out, and we had less maintenance of our public goods. And what we see as a result of this is worsening jobs, housing got worse, transportation, employment, education quality, and safety all started going down. A great example of this in the 70s was what happened in the South Bronx, where there was planned shrinkage of this neighborhood. and the government started removing essential services like fire, sanitation, public transit. They wanted kind of poverty out of there and preserve a tax base, so they figured we'd kind of lower things, get people out, clear out the smoke. But what ended up happening is what was called fulminating contagious urban decay. We were trying to kind of clean out a bad neighborhood, and we just made a worse neighborhood, and the Bronx burned. And this was kind of what exploded HIV and AIDS throughout our city, was that there was forced population migration from here. So where you live, and people don't always have that much of a choice when they're poor of where they live, really makes a difference. So what we see in this is what we call an urban minority health penalty. So in these neighborhoods that don't have the resources, that don't get the resources, you see less green space. You see food deserts, which you've heard about, which is that there's a lack of availability of healthy food. But we've also found in our research really interesting food swamps. So if you live in East Harlem, it's not just that there's not enough healthy food stores, it's that when you walk outside, you'll have 10 bad food stores for every one good one. So you're overwhelmed with crappy food. You have decreased social capital and cohesion, which is really the fabric of these neighborhoods fall apart. So like if I asked you guys who you could rely on if you needed something, if you needed money, if you needed help, if you needed a ride, you would have it. A lot of people don't. Also, these communities fall apart so they don't advocate. They're not the ones getting up there and saying, we need something, please help our community. There's concentrated disadvantage. And this is where most of these patients that we talk about spend 99% of our time. They come to us for a brief visit, and then they go back into this kind of community. And when you look at gentrification, it's a really interesting example of how this can get undone. So if you look at Park Slope, who's a very activated, very well-educated community, they're actually changing their zoning to not allow fast food in there, to not allow as many liquor stores there. Harlem's got nothing. So that's one tour, is these policies. So I want you to understand how policies can impact how and why people eat. Now I'm going to talk a little bit about stress and trauma. So we all have stressors, and we all have resources to deal with stress. But some people have more stressors than others. If you live in a neighborhood with a lot of crime, a lot of violence, hunger, people have really, really stressful lives that some of us can't even imagine. And those same people often don't have the resources to deal with them. So what we end up getting is acute stress, and there's also some genetic predispositions we're uncovering. And what happens after a while is if you have acute stress all the time, you end up with chronic stress, which dysregulates a whole cascade of things in our body. So it's like, fight or flight on steroids, and you get this wear and tear as you try to maintain homeostasis. And that leads to obesity and chronic diseases. These are shown to do this. And what we do is we have habits. We can have adaptive, healthy habits and maladaptive ones. So, do we stress out? When we stress out, do we work out or do we pig out? And we know that this chronic stress leads to a preference for energy-dense foods. We also know that this goes deeper than that if you find women, for example, who've had stress in their lifetime, they will have children who have greater problems. So stress in women leads to stress in utero, which leads to epigenetic changes, which leads to changes in the next generation. And we know that this chronic stress leads to increased CVD, diabetes, poor mental health, increased mortality. And this also impacts our patient. Next stop on our whirlwind tour of things that are making our patients fat that we don't always think about. Chemicals. So we'll call these chemicals obesogens. And you've probably heard about a lot of these chemicals. And all of these chemicals are associated with either increased BMI, insulin resistance, or glucose intolerance. So these are things like pesticides, plastics and plasticizers, phthalates that are in cosmetics, air fresheners, detergents, BPA, which lines our canned goods and bottles, things like in nonstick pans or microwavable items. These are all the next step that we're seeing. And when we look in some of the low-income communities who have, for example, problems with pests, we see that things like mothballs and agents that you use to spray for roaches and things that you use to spray for other small animals also have these obesogenic qualities to them. And we know that in low-income communities, like if we look at urine in some of these kids, they have higher concentrations of these obesogenic chemicals. And the last stop. I said before, we eat junk because we're told to. That's marketing. So not only is there food marketing, and you see, when's the last time you guys saw a broccoli commercial, right? So we really are marketed unhealthy foods, but what's interesting is that If you look in Black and Latino neighborhoods, you will see 2 times the use of child target materials, like little cartoons on unhealthy foods. And Black and Latino children view 80 to 90% of more of these unhealthy ads. Now, there is new volunteer marketing policies. So some of the companies that, the food companies that have unhealthy foods and sodas have made a promise not to advertise on TV these unhealthy foods, but they really don't have to. Because what happened is they just moved to another area. So what you see now is these advert games. I don't know if any of you have kids that go on and try to look for computer games. You'll see how many of them are sponsored by a junk food, by someone making unhealthy food. And we know these increase unhealthy consuming and test by 40%. There's smartphone apps and all sorts of things. 5 out of 10 of the top Facebook brands are at healthy foods and beverages. There's neuromarketing to subconsciously influence purchasing. Here are some examples. Over here is the International Congress of Nutrition, sponsored with a big Coke ad. Here we have kids about to swim with the ice cream commercials behind them. Video games supported by this. Here we have, let's see, we have Hello Kitty and we have Mickey and Cars, all telling kids to have dessert. We have unhealthy foods marketed to babies. We have McDonald's supporting soccer teams, all these kind of things. And about 1/4 of US global advertising goes to fast food, alcohol, and tobacco. So what is the result of this? If you just look simply at our highest educated quartile, college grads, versus our lowest, and look at the highest versus the lowest quartile of income, so most and least educated versus most and least wealthy, what we find is that among the low income, low education, double the prevalence of obesity, triple the prevalence of diabetes. This is not just people sitting home and saying, I just really want to be fat and sick. So what can we do? We can do lots of different things. We have to both think about increasing the supply of healthy food and ways you can get exercise, and also the demand for it, people wanting to do it more. Availability, affordability, acceptability, access, all these different things. And there's lots and lots of different things that we can do. In terms of policies, things like the Farm Bill, what are we going to subsidize? Do we want to subsidize meat and corn, or should we just not subsidize anything? Or should we raise the playing field for vegetables? Do we want to have junk food taxes? Do we want to have food formularies? Should we put a calorie labeling? Do we want to restrict marketing of unhealthy foods? This internationally is one of the #1 targets, is restricting marketing of unhealthy foods, especially to children. What can we do for consumers? We can educate people and our clinical care, what we do here. And we can look to figure out how in communities we can make healthy eating and active living a default choice. Housing, supermarkets, businesses, those kind of things. So I'm going to take you through a tour of a few of the things that we've been doing in New York City that I've been involved in, a bunch of people at Mount Sinai have been involved in. The first one is calorie labeling. Do you guys think it works? We get some yeses, we have some nos. So it was an interesting idea. What was also interesting about it is that departments of health are under such pressure to do something about obesity that they just do stuff. And they had no plans to measure it. Fortunately, other people measured it to see if it had an impact, because we can't learn unless we measure. And this is what we found. People saw and read the labels, but there was no change overall in calorie intake or purchases. In fact, there's a concern that it might have widened disparities, because at Starbucks, people ordered fewer calories, and at Burger King and McDonald's, they ordered more. So you wonder, because you know that you've seen the reports that child obesity rates are lowering in New York City? You know that's only in white kids. So all this information about the obesity lowering, actually in Blacks and Latinos, it's not going down, so the disparity again is widening. So we do have to look at these things. So what the DOH said is fast food consumers use calorie labeling on menu boards to make lower calorie food choices, which they did at 3 out of 11 of the restaurants who had also introduced healthy meals. But this was buried, this stuff. So what did we do? Do you know the Accountable Care Act mandated national rollout of it this year? And we have no evaluation of why New York City failed, why it didn't do it, so we have no revisions to increase the impact. We're just going to do what we did here. So we have to be careful, because we got to do stuff, but we have to be careful to measure what we're doing and then be humble if it doesn't work and figure out a way to fix it. Here's the next stop that the city's been doing. Scared skinny media campaigns. Can we show fat people and scare people to eat differently? So the question I have for you is, you know what we did to get people to stop smoking, right? We demonized smokers. You can't smoke here, you can't smoke in front of me, you can't smoke there, you can't smoke there. We can't do that to eaters. I mean, what is granola bar? Is that healthy food or junk food? We don't even know. And what the concern is that media reports like this of people can really increase stigma, especially fat neighborhoods, cities, regions. I was just in Mississippi last week doing some obesity policy work. I mean, when people think Mississippi, like one of the first two things they think of is fat. This is not necessarily helpful. And what happens is when we do this kind of portion control, the calorie labeling thing, we put up some ads of fat people to scare people, then what ends up happening is we say, dudes, all you fat people, we gave you labels, we gave you incentives, we educated you, and you're still fat, you don't care. I'm washing my hands of this. Clearly, it's all your fault. And this leads to what we call obesity stigma or obesism. So here, did you guys see these ads or hear about these ads? This was New York's Scared Skinny campaign. So over here, so you see these two people, they're both overweight, they're both dark-skinned. This guy to me looks young, he's heavy, he's hunched over, and it says type 2 diabetes is grown. So he clearly drank too much soda, got diabetes, and look, it must have made his leg amputated, right? Which is weird, right? Because do you guys amputate legs of like, what is he, 20? Right? So it's a little weird, and here's somebody else. So we looked at these and we thought these were kind of funky, and we asked the city not to roll them because we were a little bit concerned. But they did. And what happened is that there was a backlash because people said, wait a minute, how come there's no fat white people? And you know, there's a lot of racism already, so you're kind of mixing a toxic combination of discrimination against overweight people and discrimination against black people. And when we thought that this guy couldn't have had the amputation, this is what was said by the two-legged, non-diabetic model when he found out about this photo, because they airbrushed out his leg for the photo. They said, you're in New York City, for God's sakes. Give it to us the right way or we won't believe you at all. So here's two things that people tried really hard. Calorie labeling, didn't really work. Scared skinny, seems to, if anything, push people away, and lead to what we see as obesity stigma, which I would like to caution you all about. Obese adults report facing daily discrimination and facing doctor discrimination. 70% of obese people say their doctors discriminate against them. And they're right. We admit that we do. It's hard to imagine that doctors would, even if doctors felt it, I can't imagine many doctors would admit to being racist or sexist. But 50% of us in the last survey in 2009 rated obese adults as non-compliant, 30% as lazy. And we've been shown we spend less time with our obese patients and provide them less health education. We also misdiagnose their shortness of breath and their rashes and a host of other things. And what would you do? They forego health care because you don't want to go in the doctor and get yelled at from when you get weighed and get shamed. So we're actually adding stress. So I think we need to be careful about this. We all know how frustrating it is, and you heard it in these cases and other ones recently about how hard it is to do surgery with obese patients. But we have to be careful. Here's another kind of fat-shaming ad. You know, it's hard to be a little girl if you're not. And here is community backlash. This is what we have to be careful of. So we got to do better. Bypass is important, but I just said 50% of African American adults in this country are obese. We cannot bypass our way out of this situation. We have to have other tools in our chest. And in some ways, it's kind of like the water's pouring into the sink is plugged, and we're mopping the floor. So it's necessary, but it's not sufficient. We all need to keep doing our jobs, but what else can we do? Here we are in the clinical setting, improving our care, trying to improve health. And here's what's going in community with social determinants to improve health. And here's public health. We need to work together. We need to figure out the best ways to do things together. We need to merge our clinical and the community approaches to find evidence-based good ways to do this, to enhance all our capacity to influence policy. If docs and patients go to the Hill together and complain about something, it's got way more power than one of us alone. So I'm going to end with a few examples of what we're doing in East Harlem and in New York City to show you what I think the light is at the end of this tunnel. You guys know this, right? East Harlem, Upper East Side, separated by one city block. East Harlem, non-white, poor, undereducated, unsafe neighborhood, most obese in the city. 16 times the rate of diabetes amputations among seniors than the Upper East Side. Highest death rate for diabetes in the city, highest mortality in the city. Upper East Side is all the best in all these. You guys know this, right? North of 96th Street, south of 96th Street. Stark, stark, stark differences. So what are we doing? We have some stuff that we've started to do in our area that's proven effective that seems to slowly start making a difference. School programs to increase activity and improve food. Worksite programs work really, really well. Who's the largest employer in East Harlem? Mount Sinai. Peer-led, community-based lifestyle. We have these going all throughout East Harlem now. We have peers teaching others how to eat healthier and lose weight. Other things that we're starting to implement and evaluate, have you guys seen bike share that we're now trying to get up here? The green carts, which are in East Harlem. Here's our healthy program, our weight loss program in the community. We've been funding healthy food businesses, mobile vans to sell things. We have gardens, vegetable gardens growing in low-income housing to help kids eat healthier. So there's all these kind of things that we're doing. We're making better ads. Here's an ad to take the stairs. That prompts stair use by 50%. Signs saying take the stairs, right? And there's bills trying to get stairwells in the middle of buildings. We're trying to get green buildings instead of on the side. And now we're trying different kinds of ads. So not saying you're fat, but look at what you're getting. It takes you this long to walk off a soda. If you drink one soda a day, you eat 50 pounds of sugar in a year. So in conclusion, look at the whole picture of what makes us ill and what makes us well. You got to recognize that what your patients come in with is really complex. And I urge you all to keep these disparities on your dashboard. In surgery, you're only going to know if there's differences between your patients if you look by race, look by ethnicity, and see their differences. And if we look at them, we can do something about them. Gather evidence. Don't just put out calorie labeling thinking it's going to be great and pretend it's great. Not everything works, even if you think it will. Fix it if it doesn't. And if it works, you can get resources to disseminate it. And please, when you're not at work, think big, think teams, think partnerships, because I think that we as docs can do a lot to move this movement forward. And I want to thank our funders, and I want to thank you.